Welcome, and welcome to everyone watching. Hopefully Luke can sort his audio out.
Good.
Any improvements? So just for those who will be presenting, Darren, you're an ST6, is that right?
Yes.
Breast trainee, previously done a PhD. What was your PhD in?
Epigenomics in cancer.
Oh, wow. Yeah, that's some intense stuff. So this session is equality and COVID. Is there anything particular you'll be looking for from the presenters, or just a good show?
It's a good show, really. I'll be quite interested to see what sort of different aspects of the presentation they're going to give, especially, you know, following COVID. Or it'll be interesting. It'll be a good thing to look at, and listen to.
Yeah, awesome. Luke, any better?
Any success? Can you hear me?
Yeah,
yes.
How are you, Luke?
Very good, very good. Looking forward to some really good abstracts here.
Yeah, and so Luke's urology trainee. Yes, 5? 6? 6. Yeah, sorry, I won't demote you. So what we'll do is I'll bring Sherwa Sheikh Ali on in a moment. And then once the presentation's up, I'll come off and we can crack on. So Darren and Luke, just for ease, rather than me booting you off, if you leave, then after each presenter, you can just play your screen and come straight on.
Can you just repeat that? It went a bit fuzzy, sorry.
Sorry, yeah. So when if you click leave on the screen, after in a moment, when you want to rejoin, I don't have to let you back in, you can just join.
Okay.
Awesome. See you in a bit.
See ya.
Yeah.
So let me just get my notes. So Sherwa Sheikh Ali, fantastic. You've shared your screen. Darren, have you clicked leave? So Sherwa should be coming on very soon. Sherwa, how's it going? Are you on yet? I've accepted you, so you should be coming on the screen soon. Just while we wait for him, everyone keep an eye out for the polls, for which specialty you're interested in. And there'll be a chat both for the whole event and for this session on the right. So if you've got any questions for the person presenting, just throw them in there. Let me just see how the show is getting on. I'll just send the chat. Oh, here we go. Perfect. Hey, Sherwa, how are you doing?
Good, thanks. Yeah, how are you?
Perfect. Yeah, no, very good, very good. Less nervous than I was earlier. So you're try sharing your screen. Your presentation is titled "Surgical Human Resources According Types of Healthcare Facility: An Assessment in Low and Middle Income Countries." We'd really appreciate some questions from other people watching, and we'll ask you a couple of questions at the end. We're not super strict on timing, but I'll give you a warning at 5 minutes and you can just wrap up in your own time. So if you want to share your presentation, make your presentation big screen.
Can you say?
Yeah, I can see that. I can see that, yeah.
Can you all see that?
And so for anyone, for anyone watching, if you want to maximize the presentation, just double click it. And another way to make it bigger is up on the top right-hand side of your corner next to the green dot and 95, there's an arrow which you can hide the chat panel. So if you want to maximize this particular slide, then go for that. Okay, so Sherwa, whenever you're ready, go ahead.
Yeah, perfect. So morning everyone, so my name's Sherwa. I'm on the CT2s in the Northwest at the moment. I'd like to present a collaborative study that I performed with the World Health Organization assessing surgical human resources according to different types of healthcare facility in low and middle income countries. So the first question is why? Why is global surgery important? Well, it's important for a few different reasons. Namely because 5 billion people don't have access to safe and affordable surgery and anaesthesia when they require it. And the poorest third of the world's population only receive 3.5% of surgical operations conducted worldwide. And almost a third of the world's burden of disease is caused by conditions that actually surgeon. There's a common misconception that actually scaling up safe surgery anaesthesia in these countries is too expensive. Well, that's actually completely wrong. Untreated surgical disease burden costs these countries up to 12.3 trillion US dollars in lost economic output. And it says over here as well as stats that say that 81 million people face financial ruin as a direct result of expenses they incur while receiving surgery each year. And it's been proven that surgical interventions in these countries are actually significantly cost effective. And this is when you compare it to standard national health interventions, for example, antiretroviral drugs for HIV or rehydration therapy. And that's in terms of the cost per disability adjusted life year that is averted. So moving forward, now we know that global surgery has been acknowledged as a critical component of the post-2015 global health agenda, and it's critical for realising sustainable development goals set by the UN. In fact, President of the World Bank, Jim Yong Kim, has stated that surgery is an indivisible, indispensable part of universal healthcare. So what well, the GISC was set up. This is a global initiative for emergency essential in 2000, convening stakeholders, with ministers of health, surgeons, and researchers from around the world. And one thing that through something called the Standardized WHO Situational Analysis Tool. And this is essentially a cross-sectional survey form used to capture and quantify surgical capacity within low and middle income countries. So the aims of our to lead were twofold. One was to figure out who is providing countries and where are they providing it from, at what levels of healthcare facility. And to do this, we use the WHO situational analysis tool. And this captures over 100 different data points, looking at 4 kind of key sections. So infrastructure, healthcare personnel, the availability of interventions, and the availability of surgical equipment. And in terms of methodology, we included data that was captured from various levels of healthcare centres, whether these were kind of healthcare centres all the way up to tertiary, missionary kind of level hospitals. And we excluded any data that was incomplete. So in terms of our results, we captured data from 35 countries, namely Sub-Saharan Africa, Asia, and South America. And this is just goes through kind of a methodology where we ended up with 35 countries and just over 1,300 healthcare facilities for the final inclusion criteria. And this graph demonstrates the different types of healthcare facility. So we start off with a blue chart here, which shows healthcare centres, which demonstrate kind of the lowest level of healthcare facility, all the way up to kind of private missionary hospitals at kind of the highest level of healthcare facility. And we can see that the bulk of care has been provided at these low-level facilities at health centres and district and rural hospitals. And now, this is quite an important slide. So now, of all the healthcare facilities that we included in our analysis, we can see that the bulk of surgical care is actually being provided by general doctors providing surgery. So we can see that's at 27%. And I've highlighted in yellow that surgeons are actually providing less than a quarter of the surgical care at these healthcare facilities within low and middle income countries. And if we break this down according to different types of healthcare facility, so on the x-axis we have different types of healthcare facility, and if we see healthcare centres, which are the lowest level of healthcare facility, we can see that in red we have surgeons. And actually, we can see in blue that the general doctors are providing the bulk of surgical centres. As we go along the x-axis to the private NGO missionary hospitals,
5 minutes.
you can actually see they're requiring the bulk of care. So essentially, our analysis demonstrates that general doctors provide the majority of surgical care in these countries, and that non-physicians make up a key proportion of the workforce there. So I'll just go on to the next slide for timing. So how can we improve? What are the next steps now that we've acknowledged that surgery has been provided by a lot of non-physicians? Well, the first step is defining what needs to be done moving forward. And there are 3 key concepts called the bellwether procedures set by the WHO and the Lancet Commission. And that is determining whether if a hospital is able to perform a C-section, a laparotomy and treat an open fracture, they are able to provide a basic level of emergency surgical care. And we break this down into different global surgical indicators, looking at preparedness, delivery, and impact. And the key thing I've highlighted in yellow here is that we should be aiming for at least 20 specialist surgical workforce per 100,000 population. And one of the key concepts is task sharing. So the international classification of healthcare workers has defined that non-surgical personnel have the scope to carry out certain surgical procedures. And certain countries in sub-Saharan Africa have adopted the above, for example, C-sections and abscess drainages. And these programs are cost-effective, they have good outcomes, and they have better recruitment and retention of these staff. But to allay fears of quality and safety of having non-physicians providing this care, what we're calling for is standardised competencies and formalised training programs to be established. So our findings were published in the World Journal of Surgery, and it culminated in a resolution being passed at the World Health Assembly on strengthening emergency essential surgical care as a component of universal healthcare coverage. Some limitations to our study. Here are references. I'd like to acknowledge the whole team, the Lancet Commission, the WHO, and King's College London Centre for Global Surgery as well. So I appreciate that was quite a quick run through, quite a big study, but I'd like to thank you for listening and welcome any questions.
Thank you, Shoa. That was great. So we'll just bring the judges back on. Shoa, if you just come back with some questions, and I'll just let Darren back in. Luke, what did you think?
Yeah, can I start with a question? Is that okay?
Yeah, I don't know where to start.
You are?
See if we can bring him back on. We've got plenty of time, by the way. So if we do have something like this, don't stress. Showa? Here we go. I'm bringing him back on.
Oh,
yeah, Luke, go for it.
Hi, Showa. I thought that was a really great presentation. My question is do we have any data in terms of the outcomes of surgeons versus non-surgical doctors and surgeons versus other healthcare professionals? And do the outcomes and complications differ?
Yeah, it's a very good question. So our study is obviously focusing purely on who's providing surgical care. But there have been quite a few different meta-analyses which have been conducted. So, for example, there's meta-analysis in Tanzania looking at emergency obstetric surgery, comparing surgeons and clinical medical officers, and in terms of looking at the maternal mortality rate. And there's actually been no discernible difference in maternal mortality rates, perinatal deaths and complications from surgeons and clinical medical officers within these countries, actually.
Well, given that, do we think we need to be changing everyone into surgeons, or are they doing well as they are?
Yeah, so what we're saying is that actually they're doing quite well. And in order for us to upscale for surgery, we need to formalise training programs and regulations as well. Because initially, a lot of cost sharing was a temporary stopgap, which was kind of persisted on since then. So we need to make sure that training programs are formalised, there is good career progression, and the safety risks and legal risks from the regulatory point of view sorted out as well.
Fantastic. Darren, anything to add?
Hi, Shoa. Thanks for your presentation. It's really interesting. I've got two questions. Actually, one stems from Luke's question. So looking more at the general doctors who are doing a bulk of the operations, have they had previous training from surgeons, seeing that they're able to be doing the bulk of the operating? What's their background?
Yeah, so a lot of the work is informal teaching. So informal teaching from a few surgeons at tertiary hospitals, and as part of their clinical medical officer training. It's not formalised training. So often they'll shadow surgeons, for example, and go back to the district hospitals, perform some cases and kind of learn on the job. But there aren't many formalised training programs that are set by the various colleges within, for example, South and Eastern Africa.
Okay, thanks. And the second question is training standardization. So how do you, I mean, that's a massive undertaking. Not saying that it's not impossible, but how would you set up a sort of brief framework of that to make sure that everyone's, you know, for example, a level 4B for a laparotomy, how would that extrapolate into your training program?
Yeah, absolutely. It's a very good question. And that actually goes study, because our study is obviously just mapping out who's providing surgery and what level of healthcare system they're providing. But one key thing is having a uniform program set by the colleges, so the Royal Colleges. We've got Royal Colleges here, Royal Colleges there, need to set out definitions of how well a procedure should be formed and how a procedure should be formed, for example. But it has to be uniform and localized. But that goes kind of beyond our study, actually. That's kind of the next step.
Okay, great.
Right, thanks, Joe. So I'll kick you off. See ya. And then judges if you leave. And next up is Nina Al-Sadi. When you're ready, share your screen. Fantastic. I'll bring you on. So Nina's presentation is titled "Cut from the Same Cloth: The Experience of Hijabi Women in the Operating Theatre." And I'm certainly interested to hear about this one. Do you want to try sharing your screen? So it should be the little white box with the red line through it. And for everybody watching, the chat function, there's a specific one for the session. So under chat, you'll have event and session. You can click session and send in any questions you've got. Nina, that's great. That's on. Are you happy to start? Yep. So whenever you're ready, and we can hear you really well. And just before you start, remember, anyone who wants to maximize the screen, just double click on the presentation.
All right, so hi, I'm Nina. I'm a CT2 currently working in the East Midlands. And for the next few minutes, I'm going to be speaking to you about the experience of hijabi women working in the operating theatre. So to give a bit of a background, this project was actually inspired by an experience I had as a third-year medical student on my first surgical placement. I was really excited to go to theatre, and when I showed up, I was asked to go back to the changing rooms, put a scrub cap on, and then come back. But when I did that, the scrub nurse stopped me at the theatre doors, asked me to either take that off, pointing to my headscarf, and come in, or otherwise I would have to leave. At the time, I assumed this meant I wouldn't be able to pursue a career in surgery whilst preserving my personal choice to wear a hijab, and I just wanted to see if other people had experienced anything similar. So to begin with, when we look at workforce diversity in surgery, the NHS National Workforce reported that 10% of the medical workforce at the moment in the UK is actually made up of Muslims. However, despite this and the fact that over the last decade, there have been efforts to tackle barriers that women face when pursuing a career in surgery, hijabi Muslim women have still been reported to be surgery career dreams. So what we wanted to do was to evaluate the experience of medical professionals who wear the hijab in UK operating theatres, identify if they had any issues when doing so, and then if they did have any issues, look and see at how we can tackle these. We did this by designing and distributing an online questionnaire nationally via multiple Muslim networks to hijabi medical students, healthcare professionals, and also doctors who work in operating theatres. So overall, 35 hijabi medical professionals, from medical students all the way to consultants, participated and filled out the questionnaire. I'd just like to highlight that despite the fact that it was distributed nationally and via multiple networks, only 7 of the doctors were surgical trainees, fellows, or consultants. And I feel this really reflects the lack of hijabi doctors who are actually working in surgery at the moment. The first thing we asked them is what they would do regarding the hijab when they were actually scrubbing into theatre. The majority of women stated that they kept it on and put a scrub cap on top. 11% reported that they felt the need to remove it and wear a scrub cap on top instead. And only 11% said that they had a hijab-specific scrub cap, which was offered to them by the hospital. We then asked them if they'd ever felt worried or anxious about wearing a hijab in theatre, and 77% of the participants stated that they had at some point during their education or training, and 54% reported that they had been asked to remove their hijab in order to enter theatre in the past. We also asked them in free text to describe their overall experience of wearing a hijab in theatre. 32 of the 35 participants reported that they had had issues with it in the past. They reported that they'd received negative feedback or felt stressed or anxious about wearing one. And some also reported that it has put them off working in surgery or pursuing a surgical career. Furthermore, 86% of the participants actually said they'd be more inclined to go to theatre if hijab-friendly scrub caps were available. And at a time where we want to encourage as many people to come to theatre and pursue careers in surgery as possible, this was quite relevant. And also, all the participants actually felt more should be done to facilitate women wearing a hijab in theatre. And when asked to describe their suggestions, they noted simple steps like offering hijab-friendly scrub caps or just having NHS guidance, which was available to everyone. In conclusion, our findings highlight that many Muslim women who choose to wear the hijab have found it difficult to go to theatre and have avoided going to theatre and pursuing these careers because of the fact that they choose to wear a hijab. And we've shown that simple steps such as having sterile hijabs or hijab-friendly scrub caps, or also having hijab-specific dress policies that are known to everyone, including the scrubbing staff, could help to improve this. And that can help us have a more diverse surgical workforce, which not only supports individuals' talents, but also improves patients' overall experience and care. Thank you.
Fantastic. That's really interesting. Thanks for that, Nina. So let's bring the judges on and see what questions they've got. Okay, so Darren, do you want to start us off?
Hi, Nina. Thanks for a really good presentation. Very interesting. So my first question is based on reporting. So there was quite a few number of reported people, as you mentioned in your presentation.
Yeah.
What do you think that's due to, in terms of surgical trainees? I mean, because there's far more than 7.
So we did distribute it nationally and through multiple Muslim networks. But with respect to surgical trainees, we were looking at specifically the ones who were wearing the hijab, and we only left the survey open for 10 days. So I do feel an extent of it could have been reaching these networks even further. But I do feel also it just represents how many Muslim women are actually wearing hijab and working in surgery. So, for example, at my trust, it was only me last year, and there are 3 of us this year across the East Midlands.
Okay. And the next thing is, with regards to, going forward and actually wearing something synonymous to a hijab that would give you the comfort from a religious point of view, but also the safety from a surgical point of view. So in my experience, I've seen that orthopedic surgeons, they use a type of scrub cap that covers the head and the ears and goes around your face. Is that something that could be used or in conjunction with to answer that question for you?
So no, definitely. As in when I was in F1, that was the solution that I actually found to be able to going into surgery, and I found the orthopedic sort of surgical hoods. The only problem at the time was that they were only available in the male changing room, so I'd have to ask someone to grab them for me and then go. But after I knew that, I spread that knowledge to the people that I knew and let like medical students, etc., know that was available. I think it's just almost raising awareness about the fact that these options are available if you look for them.
Thank you.
Good. I've actually got a question about nurses, because I noticed that I think most of your responses doctors. Are you aware that more nurses who wear hijabs go into sort of non-surgical specialties, or is that something that's a barrier in nursing and nursing training, or is this something that's unique to doctors?
So I think it's something that could be, and I think it's something that I'd be looking into in the future and seeing if it is something that they also saw as a barrier. A lot of the people I've spoken to individually, so not through the study, have reported they find it easier to just take their scarf off and wear a scarf cap instead, just to avoid any confrontation or any uncomfortable conversation before having to go to work.
Mm-hmm. Okay. And in your hospital, are these hijab sort of friendly scrubs or coverings? Are they available?
So in Leicester, you're actually allowed to wear your assessment hijab to go into theatre. So I wear one similar to this one, but just one I haven't worn out there, but I wear it in theatre without anybody unaccepted. There was actually a NHS guidance which was published back in April, which stated that as long as you have a clean hijab, you should be allowed to wear it in theatre. It's just that guidance was available before this year.
Luke and Darren, just mute your mic just for a moment. It just might help a little bit with the echoey. A couple of questions just from other people watching, so thanks for sending them in. Sakina has asked, are there any guidelines available for NHS Trust regarding hijab and uniform policy?
So there are now. So in April, guidance was published by the NHS. I think it's just raising awareness about that guidance. But again, that you can wear a clean headscarf and go into theatre. Before that, it would depend on local policy. So some trusts prohibited wearing a covering at all, whereas some trusts said you could wear a cap on top. Fine.
And then from Carolina, do you feel anything has changed since your initial experience as a third-year medical student?
So for me personally, it has. But when I've spoken to medical students, a lot of them have still see it as a barrier. So I think again, it's about raising that awareness and making the guidance more present.
Fantastic. Thank you so much. Really interesting, and I hope
can I just add one more thing?
Those of you watching who've seen these presentations would be keen to join us for the Equality and Diversity panel later. Obviously, it's not exactly the same, but the fact that you've gone through these experiences shows that it is something we need to be talking about. Okay, Darren's got something just to add. Go for it, Darren.
Can you hear me?
Yeah.
Yeah, I was just about to say maybe there's a good business case to start manufacturing hijab-like sterile equipment to go to theatre. You know.
So recently they started a mock-up in Derby. I think Derby's the only trust that does that, where they've now got sterile hijabs since I think about June. But no, definitely, and to continue that across the course in the UK.
Fine, thanks.
Yeah, thanks.
I'm not muted anymore, thanks, sorry. So just to say that we're not in a massive rush, so if there's lots of questions and it's really interesting to you, do send them in, and I'm happy to send them all to the presenters. Max, how are you?
Yeah, not bad, thanks. How are you?
You enjoying it so far?
Yeah, very good, very good.
Good. We'll try to mute Darren whilst you're answering his questions. And then we'll bring him back on when he asks them. So, Max, do you want to try sharing your screen, and then I'll just let you know that it works fine?
Yeah.
Yeah, that's up.
Yeah.
Fantastic. So, whenever you're ready, you can start.
Okay. So, yeah, hi, my name is Max. I'm going to talk today about the impact of socioeconomic background, gender and ethnicity on MRCS exam outcomes. There have been previous studies showing associations between ethnicity and gender as independent predictors of success in the MRCS exam. Ethnicity actually is associated with both parts A and parts B, but gender was only associated with part A. No one's to date looked at socioeconomic background and its effect, so our aim was to have a look at that. We got a reasonably large amount of data, about 3,000 exam attempts from the GMC. So socioeconomic background is based on this index of multiple deprivation. That is basically based on the postcode of students when they apply to medical school, and the area gets an IMD rating basically from Q1, the most deprived, to Q5, the least deprived, and it's based on relative weighting of income, employment, education, health, crime, etc. in the area. So looking at pass rates for parts A and B combined, you can see there that the most deprived quintiles, so Q1 and Q2, have a significantly lower pass rate than the mean pass rate. So that's why they're coloured purple, because they're outliers and they have no overlap with the mean pass mark of about 57%. So you can see there that Q1 and Q2 trainees have pass rates of about 45 and 47% respectively. And you can see also that they have significantly lower pass rates than Q4 and 5 trainees, as there's no overlap with those data. So yeah, just to point out as well that, I mean, I don't think it's a huge surprise that amongst surgical trainees, there are far more people in the least deprived groups.
Matt, I'm really sorry to interrupt. It's just, it looks like your slides aren't going through.
Oh, right.
Don't worry. So just, I'll unshare your screen.
Okay.
Like I said, we've got plenty of time. If you come back on, and then if you start your slide before sharing and see if that fixes it.
Oh, should I? Okay.
It's not your fault. Just the way the software brings the slides in is sometimes not brilliant. So start your presentation now and then share the screen.
Okay.
And I'll restart the timer. So
I'll share the entire screen or the application window. I was doing just the application window. But...
Try either. It should work.
Okay.
Thanks for bringing this to my attention. I was sorting some other bits and bobs out. Yeah, that's brilliant.
Is it going through now? Or...
Yeah, perfect.
Yeah. So right. Just.
Do you want to start again?
I'm happy to if that's what you like.
Yeah, go. It's really interesting. It'd be nice to be able to see the slides. So
they're working now. They're going through. Yeah. Okay. So yeah, just basically to say that. So previous studies have shown ethnicity and gender both to be independent predictors of success in the MRCS exam. Ethnicity actually plays a part in part A and part B, but gender has only been shown to be associated with part A results. No one's looked at the influence of socioeconomic background, so our aim was to basically look at that. We got about 3,000 exam attempts in data from the GMC, and it's based on this index of multiple deprivation. So that is based on postcode of the applicants when they apply to medical school, and it's weighted on income in the area, employment, education, health, crime, barriers to housing, etc. And Q1, so quintile 1, are the most deprived students, and Q5 the least deprived. Now, obviously, that's not the most accurate way, but that is how generally big data is, in terms of socioeconomic background, is measured. So if we look at pass rates for parts A and B, the most deprived candidates in Q1 and Q2 have significantly lower pass rates. That's why they're in purple, than the mean, but also significantly lower pass rates than the least deprived candidates in Q4 and Q5. So their pass rates for Q1 and Q2 are about 45 and 47% respectively, and that's for both parts combined, compared to Q4 at 60 and Q5 at 62%, and the mean at about 57%. So yeah, just to point out that, you know, these sort of inequalities exist, that the most deprived candidates make up a far smaller proportion of candidates than the least deprived as well. So if we split those numbers up into gender, we look at the most deprived, the candidates from the most deprived quintile, male ones, they have significantly lower pass rates, about 45% compared to the mean, but also significantly lower pass rates than those in Q3, Q4 and Q5. Now, in the female group, there's not the same association. All the data sets overlap. However, what's noticeable is that the average pass rate for both parts for females is about 51% compared to 62% for males, and that's pretty shocking. So in terms of, we break the same group up into ethnicity, this time the groups are grouped into Q1 and Q2, so the most deprived students, and Q4 and 5, the least deprived. And there's a pattern in the BME group. Now, BME, of course, is quite a general term, but it's how the GMC data is grouped, so that's what we've got. The Q1 and 2, the most deprived groups, are considerably lower pass rates than the Q4 and 5 groups. There wasn't the same pattern amongst the white trainees. However, you can see again that there is a significantly lower pass rate, about 51%, compared to the for the BME trainees compared to the white trainees at about 62%. So unsurprisingly, this is the results for passing both parts at the first attempt. 46% in the most deprived and 63% in the least deprived. Now, these are statistically significant with a p-value of less than 0.001. And it follows on that the number of attempts for both parts is significantly higher in those trainees from Q1 and Q2 compared to the least deprived trainees. So in summary, in terms of gender and ethnicity, if you group the two exams, females have significantly lower pass rate than males, and BME trainees have significantly lower pass rates than white trainees. And if you look at socioeconomic background purely, the most deprived trainees from Q1 and Q2 have lower pass rates, are less likely to pass both exams at the first attempt, and therefore have a significantly higher number of attempts. So what's this study shown? It's shown there's a significant association, or likely, between socioeconomic background and MRCS results. So that means in turn that those from most deprived backgrounds are going to have to take the exam more times and incur more costs. Reasons behind this are undeniably complex and multifactorial. There are studies showing socioeconomic background affects academic achievement at all levels, from school, medical school, and even the UK Foundation Programme applications. And then there's another, like a more recent study, 2018, that shows prior academic achievement at medical school is a predictor of later, so MRCP examination outcomes and entry onto the specialist register. Now, there are more speculative reasons for why this might happen, inability to pay for expensive revision courses and resources. So in terms of what we're going to do next steps, we've already got quite big data from UK Med, and the aim is to control for prior academic achievement so that we can separate whether this is purely socioeconomic background or whether there's, a muddying factor of the fact that prior academic achievement is weighing into this as well. So yeah, that's it. Those are the studies that I was talking about, and yeah, happy to take any questions.
Fantastic. Okay, so we'll bring the judges on. Luke. So I'll mute myself. Luke, do you want to start us off?
Yes, yeah. That was really good. Data on people end up actually passing in the end.
I can't really hear you. I think it's Darren's microphone again. Oh, yeah, that's better. Yeah.
Yeah. So my question really is about the general outcome for people after this, because we know that most people who do go to the MRCS eventually end up passing, whether it's a few times. And is there a difference in sort of the low social economic demographic people? Are they more likely to give up due to lack of money, and we know the costs are very high? Or all these people end up going on anyway and still having successful surgical careers?
That's unfortunately not covered by the data that we've got. I mean, what we can see from that data is that because the number of attempts is significantly higher as well, I think they do keep coming back to do more attempts. I don't know for sure whether people give up at a certain stage, unfortunately. I mean, that's something we could look at with data. We did actually ask the GMC for that data, but they weren't able to provide it. I think it's quite difficult to tell whether, people stopped attempting it.
Mm-hmm.
Can't hear you, Tom.
Darren, go for it. Sorry.
Hi, Max. Thanks for the presentation. I've got two questions. So the first one is based on your postcode algorithm for understanding socioeconomic classification. It reminds me a bit of the A-level results problem that we had a few months ago. So how was that calculated, if you could tell me briefly?
Yeah, so I mean, it's obviously not a flawless system, but it's what we looked into. It's basically how they do look at socioeconomic background on any large scale data. So it's this index of multiple deprivation. It's based on postcode, so obviously not completely reliable. There are going to be people in mansions within like not so good postcodes that it won't count for. But it's the only way, the only reliable way they found of doing it sort of on a large scale that's not looking individually into, I guess, household income and things like that. It's based on area, income, employment, education, health, crime, barriers to housing and services, things like that. So there will always be outliers. So yeah, it's not flawless, but it's the way that all the sort of big government data is done at the moment. It falls down with graduate medical students a bit, because they've often, moved by the time they apply for medical school, and they've been from a completely different socioeconomic background to now. And yeah, there are definitely flaws, but we tried doing a survey on household income before, and it's quite difficult to pull estimations, and there are inaccuracies that come in that, because it's basically questionnaire based rather than anything. So I think it's the best that we've got, but definitely not flawless.
I also think maybe when you do a subgroup analysis, you'll be able to filter out those biases a bit better.
Yeah, that's what we're hoping. We're hoping that like the UK med data, I think, is going to be sort of bigger and hopefully be able to do a bit more of the subgroup stuff. Yeah.
Thank you. It's really interesting. Thanks.
No worries.
Okay. Do you mind if I ask one more question?
Sure.
Could I just ask, given that most people who take the exam have been doctors for at least a year, do you know is this something that is a decreasing factor, and does the same thing pass on to FRCS examinations when people have been doctors for at least sort of 8-9 years, in which case their socioeconomic background may be different than when they started?
Yeah, it's a really good question. That's definitely something we'd like to look at in the future, and it's part of the difficulty of even starting to talk about bursaries and things like that, because by the time they've taken these exams, like you said, people have been earning for a year or two. They have their own income, so basing bursaries on financial means and means testing things starts becoming a bit more difficult. I don't know about the FRCS exams, and like you said, it shouldn't be having such an impact. I guess, like we all know, and probably if you've just come out of medical school and you're an F1, I think that having parents that can support you in for exams and courses is going to make a big difference at that stage. Whether it at FRCS, I mean, there are some people that get parental help from at that stage as well, but yeah, difficult to tell, and definitely something I'd like to look into.
Thank you very much. Really good.
No worries.
Okay, thanks, Max. Fantastic. So I'll send you on your way. So far, so let me bring up the next presenter. So that will be Carolina Waters with her presentation titled "Virtual Voice Clinics in the COVID-19 Era, Are They Here to Stay?" Which is very interesting, something I've been doing where I'm working at the moment, and the judge for the urology room also is working on, and I believe there's something being presented in their room on virtual voice clinics, so obviously very popular. Hi, Carolina. Okay, let's see, try and unmute yourself, or no, sorry. Can anyone else hear her? You can always try logging off and logging back on and seeing if that helps. No, sorry. Okay, where are you? Here we go. Bring you on now. No, I can't hear you. When you're sharing screen, does it give you the option and stuff like that? And don't worry, there's no rush. We've got plenty of time, so we can figure this out. Okay. Why don't we bring on the next one? Carolina, you'll go after. So Hannah Waddington, you're presenting for Luke. So Carolina, if you try coming off and then just closing down the whole of Hopin and coming back in, and don't worry, we'll get you on, even if it's next or last, we'll get it done, don't worry. So Hannah, I'll bring you on. Can everyone hear me? Just let me know in the session chat. Fantastic. Thanks, Darren. Brilliant. So we'll bring Hannah on now. So the original abstract was submitted by Luke. So thank you, Hannah, for stepping in to present it. It's titled Audit of COVID-19 Awareness and Public Health Message Effectiveness in the Hospital Setting over the Course of the Pandemic. I think we can all agree that anecdotally, some of those messages were not received or not adhered to. So it'd be interesting to see what Hannah's found. Hannah and Luke.
I'm fine. Can you hear me? Okay.
Yeah, fantastic. Nice to see you again. Hannah came for our test event yesterday, so everything should work very smoothly today. No
Hopefully.
pressure.
Before I start, it's just worth saying one of my neighbours has just decided to start doing some drilling. So hopefully it's not problematic, but if it is, we'll see what we can do.
Yeah. I can see your slides, so that's great. And you can start whenever you want to.
Okay, perfect. So good morning, my name's Hannah. I'm actually a CT2 in anaesthetics in Mersey, but I'm presenting a study that was done in collaboration with some of my surgical and anaesthetic colleagues on the effectiveness of the public health message in the hospital setting over the course of the COVID-19 pandemic. Our aims were to assess core understanding of COVID-19 amongst healthcare workers and investigate the effectiveness of the information that was provided by Public Health England across the timeline of the pandemic. It was a multi-site study and it spanned all hospital staff groups, including clinical and non-clinical staff. We designed a questionnaire based on the Public Health England guidance at 3 separate points in time and assessed knowledge of symptoms, risk factors, transmission, and the most important means to reduce transmission. We conducted the questionnaire across 3 cycles in March, April, and July of 2020, and between each cycle, participants were subjected to the evolving Public Health England campaign messages. In total, we recruited 253 participants across all 3 cycles, and these were predominantly clinical, with doctors forming the largest staff group. So question 1, we asked participants to select the most common symptoms of COVID-19 according to Public Health England at that time. It's worth noting here that for the initial 2 cycles, we asked for 3 symptoms, but as new information evolved and anosmia was identified as a symptom by Public Health England, we adapted the questionnaire to include 4 symptoms in the 3rd cycle. So knowledge of the key symptoms was high across all 3 cycles, and anosmia was well recognised in cycle 3 with 88% of participants. There was some increased variability in the responses seen in the 3rd cycle, for example, with fatigue and sore throat gaining more responses. Question 2, we asked participants to select the 5 greatest risk factors for COVID-19 according to Public Health England at that time. Again, there was good knowledge of the 5 key risk factors during the first 2 cycles, and more respondents selected ethnicity in the 3rd cycle in line with the evolving information of the risk to Black, Asian, and minority ethnic groups. Question 3, we asked participants to select the most likely means of COVID-19 transmission according to Public Health England at that time. The knowledge of aerosol transmission increased from 76 to 95 and 93% respectively across the 3 cycles, and there was a corresponding decrease in participants selecting physical contact and contaminated surfaces. And question 4, we asked participants to select the most important means to reduce transmission according to Public Health England at that time. The focus on hand washing initially increased from 71 to 99% between cycles 1 and 2, but decreased to 58% in cycle 3, with more participants selecting alternative options such as face coverings, avoiding contact, and isolation. We then analysed these results by staff group. So doctors showed the highest knowledge of the public health symptoms across all 3 cycles. And by cycle 3, the lowest knowledge of symptoms was seen in non-clinical staff. Regarding transmission, initially there was quite a large amount of variation in the knowledge of aerosol transmission, but by cycle 3, all staff groups had converged with high recognition of aerosol transmission. And regarding minimising transmission, in cycles 1 and especially in 2, there was very high recognition of hand washing throughout all staff groups, but this was less well recognised in cycle 3, especially so by non-clinical staff at 22%. So some discussion surrounding this. So the increased variation in the responses seen regarding symptoms in the 3rd cycle may be due to personal or anecdotal experiences of affected friends, family, patients. Anosmia was really well reported by the media and the news outlets, and that this information communicated by Public Health England, and this was well represented by 88% recognition in cycle 3. Similarly, ethnicity was again quite widely circulated in news outlets, and that maybe suggests why there was such a large increase in the recognition of the risk posed to Black, Asian and minority ethnic groups. The aerosol transmission knowledge was really high throughout. Obviously, in the hospital setting, there was a lot of concern surrounding the risk posed by aerosol generating procedures, which may explain why there's a high knowledge of this transmission route. And regarding minimising transmission, there was quite a large reduction in the perception of the importance of hand washing, and we wondered if this may in part be due to the multiple mixed messages that were received from Public Health England and emphasis on other strategies such as face masks, which were enforced from July, lockdown, isolation. We did note a limitation to our questionnaire as we were analysing the data, and this is, some of you may have noticed, there's no staff group comparison for the risk factors and comorbidities. We asked for 5 risk factors, and as new information evolved, we did not adapt our study really to account for this. So we felt like we couldn't compare what we deemed the correct answers were between the staff groups. So in conclusion, there was really good knowledge of the common symptoms and the aerosol transmission route. Respondents' selection of symptoms may be influenced by their own experiences or anecdotal experiences. Participants were receptive to new specific information such as anosmia or the risk to Black, Asian and minority ethnic groups. And the fall in recognition of the importance of hand washing was possibly due to the dilution of the public health messages as more and more guidance was published. Our references, we only used Public Health England sources, and I'm happy to take any questions. Thank you.
Brilliant, perfectly timed, just in on the 6 minutes, well done. I didn't give you a warning because you seem to be doing well. Bring Karen and Luke in. I'll mute myself and then Karen, do you want to start?
Thanks, Hannah, for a great presentation. It's really interesting to look at the data. Why is it that you weren't able to get any data from staff groups, and how would you change that going forward to look at the subgroup of doctors who had the most knowledge about the messages to see which of the groups, i.e. consultants versus juniors, if you looked at that sort of analysis?
So we did take this on the questionnaire. We did ask for people's grades in their specialties. When we came to analysing the data, there was just such a sort of a mix of everything. There might be one consultant respiratory and one this and one that, but they didn't really kind of amount to any useful data to look at. So in the end, we just left them as doctors rather than looking at one person of this subtype and one person of this subtype.
Okay.
But I agree. It might be useful to look at how people's level of experience or their specialty kind of influence their knowledge and decision making.
Fine. Thank you.
Yeah. So I'm assuming that the Public Health England guidance is designed for the general public. It's not designed for doctors. So I just wanted to know, do you know how maybe the non-doctors compared to the actual general public, and what is the general public view on the Public Health England knowledge as opposed to doctors who may have an intrinsic bias having been being taught about stuff from within the hospital?
Mm-hmm. So I didn't fully hear you in the middle, but I'll answer what I heard. So the reason we use the non-clinical staff is to have a look at how kind of ordinary staff members who largely would how they'd interpret guidance. And it was, as you said, just for the general public. It wasn't for but we sort of specifically wanted to see how the method of public housing and employment affected all this, and that was the
It's the assumption there that there'll be an improvement there in the non-clinical staff. That's probably the same improvement that we've seen in the general public.
Yeah, yeah, I agree.
Mm-hmm. Good, good. Right.
I'm trying to sort out the it's okay, but if it does happen, just mention it on the side. Luke and Darren, any of the comments?
Hannah, were you able to find out how many people had actually read the Public Health England guidance? Because I know I haven't.
So, no. There were around the hospital with kind of a concise public health message. So, the key symptoms, risk factors, and the key ways to reduce transmission and circulation around the hospitals. So, this was based on the assumption that people had seen these around, and it was quite hard to miss because they're in every coffee room, every bathroom. So, it was based on the assumption that people had seen these and were receptive to them.
Correct. Carolina, do you want to retry joining and see how we get on? Okay. No audio. What browser are you using? Okay. Give it a go on something else, either Safari or Firefox, and we will keep trying. But in the meantime, why don't we bring Bryony on? Bryony.
Hi.
Fantastic. Your audio works. Okay. So your presentation is titled Triaging Patients with COVID-19.
Yeah.
All right. Fantastic. Are you enjoying it so far?
I'm just trying to share my slides.
So I'll let you know when they're up.
Sure.
Can you look?
Can you see them?
Not just yet. Have you clicked the white screen at the bottom with the red line through it?
Yeah, and I've selected my PowerPoint.
Yeah.
Click share.
Then have you clicked share?
Yeah.
Are you using Mac or PC?
Mac.
And have you set your privacy settings to allow screen recording on Chrome?
Yeah, I think so. I've done that. One sec.
Try again, see how you get on.
Sure, sorry, one sec.
Thank you everyone for your patience. Obviously this software is new for everyone, so there's plenty of time factored in. So don't anyone stress about your presentation, and Carolina, we'll find a way to get you to present. I will even present your presentation if I have to. And I will also send myself a certificate for doing it if we need to. Right. How's it going, Bryony?
So I've just changed my settings as well. I'm clicking the PowerPoint, but it's not sharing. One sec, hang on, sorry.
Can you share your entire screen?
Let's see.
So when you click the share screen, you'll have share entire screen.
Yeah, I've just clicked that.
And it's not letting you do it?
It's not doing anything yet, no.
Fine. And you've allowed Chrome?
Yeah, I've just gone on my settings. It's enabled screen sharing.
And did you just enable it just then?
Yeah, I've just done it just now.
Close Chrome, come back on.
Okay.
We've got this. We're going to get there. Don't worry.
Okay, fine.
Next up, on the starter, and then we'll go backwards. Brilliant is here. Let's put it. Third time lucky. Here we go. Fantastic. He's on.
Hello. Can you hear me?
The audio works. Yeah, we got you.
Right.
Beautiful backdrop as well. Doing well. There. We've got a clock and some art. Very nice.
Yeah. Okay. Yeah.
Let's see how your screen sharing goes.
Hopefully better than the other ones.
Yeah. It's. I think what it is because it's through a website rather than an app.
Yeah.
Unless it's all enabled before, but I factored all of this in because I knew no one would have used it before. Yep, yours is up. Perfect.
Can we see that?
Yeah. When you've started, I'll start the clock and I'll hide myself in my audio.
Okay.
Do you want to try just before you start? Just try clicking through.
Is that going?
No. So share your screen again, but start the presentation before sharing it. This is running very smoothly. Well done, everyone.
Okay.
I don't know who organised this horrendous amateur job, but I'll let them know. No, it was me. So let's go again.
Is that working yet?
So before sharing your screen, just start your slideshow. Or try putting it into presenting mode now.
Yeah, it is now.
And when you click through, we're not seeing anything.
You're not seeing anything. Fine.
So try. Oh, there you go. That was it.
Oh, I just said
it did work then.
Let's try again.
That's all right. No, don't stress about it. It's absolutely fine. We're all friends here. Okay, try clicking through.
Is that working?
Try going on to the second slide.
Yeah, I'm clicking through on my end.
Okay, right. So try. Oh, yes, it's come through. Go on to your third slide.
Now I don't have the slides on mine.
Have you shared the application or your entire screen?
I shared the application. So I share my entire screen.
Yeah, just try that and see if that's better.
Yes.
Yeah, that looks really good. Well done. All right. So whenever you're ready, you get going.
Good. So I'm Tom. I'm a clinical fellow at Norwich Hospital with an interest in orthopedics, and this is my presentation on increased 30-day mortality rates in patients admitted with fragility hip fractures. So that's what we're going to talk about today. I'm sure many of you will be aware that hip fractures are a big business. There's 65,000 a year in the UK, costing about £1 billion per year to the NHS. Mortality for these patients has historically been very high, but with the introduction of things like the best practice tariff and the National Hip Fracture Database, that's got much better. And in 2019, the 30-day mortality reached an all-time low of 6.1%. North Norwich Hospital is a big trauma unit and teaching hospital. We receive over 800 hip fractures a year, making us one of the top 5 in the country. So COVID-19 caused a worldwide pandemic and forced the UK lockdown in March, as obviously you all know, and that's had massive effects on our healthcare system. There's been a lot of early studies looking at morbidity and mortality, which show that there's very high morbidity and mortality in surgical patients. And then there's also been some American and European studies at the outset showing high early mortality for hip fracture patients specifically. When I did this study, there weren't any published papers looking at specifically 30-day mortality for hip fractures, and that was the most relevant metric. So that was the primary outcome for this paper. So we got institutional approval to proceed as an audit. It was a single centre prospective observational study of fragility hip fractures in the month following lockdown, followed them all up for 30 days, and then retrospectively looked at data from 2019 to compare. And that's the data that we collected. So key findings, the two cohorts were a similar size and statistically comparable demographically. The mortality was much higher in 2020 for overall, regardless of COVID status, but that wasn't statistically significant, likely due to the relatively small patient numbers. The increased mortality was particularly dramatic for patients who got COVID-19. So if you got COVID-19 as an inpatient, so either diagnosed on admission or during the admission, then the mortality in that group was 80%. There were some patients that were discharged and subsequently developed COVID-19 in the follow-up period, and they all survived. So for that group of patients, so if you had a hip fracture that was complicated by COVID-19 within 30 days, the mortality was 50%. Average time to theatre as well was an important metric used in the best practice tariff. The target is 36 hours. The average time to theatre was similar between both years. However, the proportion of patients getting to theatre on time was significantly less in 2020. Mortality was also higher for patients without COVID-19. That was 13.8% compared to 8.5% last year. We identified clearly that the triage system didn't work effectively for this cohort. It only served to delay theatre. However, this delay didn't confer a worse mortality for those patients. The mortality was the same whether you got to theatre on time or whether you were late. So discussion, the very high mortality for COVID-19 positive patients was, to be honest, expected, since a lot of them have many of the risk factors for increased mortality when infected with COVID-19, like cardiovascular disease, diabetes, high BMI, respiratory disease. The risk of mortality was highest if you were infected in the immediate perioperative period. The increased mortality in COVID-19 negative patients was unexpected and worrying. And we believe that this was because of a breakdown in normal operating procedures and the reduced ability to provide good multidisciplinary care. And in addition, the post-operative care was no longer led by specialist orthogeriatricians. The inadequacies in the triage system were of a concern as well. So based on our findings, we made some recommendations at the governance meeting. Routine testing of all patients, regardless of COVID-19 symptoms on admission. That's something that's now been adopted. We have also reverted to a specialist orthogeriatrician-led MDT care post-operatively. Finally, we also made some justifications for considering delaying theatre. Firstly, for patients with signs and symptoms of COVID, since we know that COVID has such a high morbidity and mortality, you'd want to know if you're operating on someone with COVID. But then in the event of another wave of COVID infections, and there could be people with who are asymptomatic. Sorry? Okay, there could be patients who are asymptomatic who operating on them could induce a COVID pneumonitis and death. So we would, in the event of another wave, we've provided a justification for delaying theatre for everyone until they've got a negative COVID test. Something that would make this much easier would be rapid point of care testing. Any questions?
Fantastic, thanks for that. Perfectly timed as well. Let's bring on the judges. Some of the other rooms are having similar tech problems, so don't worry, it's all the same for everybody. And I think it's just this software isn't quite ironed out. It's from a UK startup and it's just exploded this year. So I think they're learning just as much as we are. But anyway, let's crack on. So Luke, do you want to start us off?
Can I start? Really nice, Tom. Can I just ask a question about your overall mortality? I thought it sounded very, very high. You had two numbers of 50% and 80%. In terms of the published data, which is the last paper from the COVID surge group, they have a preoperative mortality of 23%. Why is your mortality so much higher than the surgery?
So that 80% was patients who, I should say as well, some of them didn't actually have surgery for their hip fracture. Some of them were managed conservatively. So these are elderly, frail people who come in with a COVID infection, and they're going to have a poor. There's a high risk of them having a poor outcome regardless. But our 80% was fractures complicated. Sorry, that's
No, my dog's barking.
Are the dogs talking?
Yeah, I think
Fantastic. Of all the problems we could have.
The two dogs arguing. And my other question is, did you have more patients that were managed non-surgically because of COVID?
So I think that one of the big problems with our data is that we didn't actually get very many patients with COVID. We had 66 patients in the cohort. Only 8 of them actually had a confirmed COVID infection. So the numbers seem bad, but it's not necessarily, they're not statistically significant.
Yeah.
Fantastic, thanks, Luke. So Darren, I'm just going to unmute you. Go for it.
Hi, Thomas. Thanks for your presentation. First question is, in terms of those patients who were COVID negative and sustained fragility fractures and then went on to having surgery, how many of those patients then became COVID positive?
So there were two patients who were triaged as not COVID, went on to have their procedure and then developed COVID whilst an inpatient. They were at 7 and 10 days. So it's unclear whether they were asymptomatic incubators at the start or whether they're nosocomial infections. So again, it's quite small numbers, but they both died within 30 days. So.
Oh, that's unfortunate.
Yeah.
Second question is in terms of...
Sorry, Darren. Just hold on. I had muted you just because of the echo. So you go for it again. Start that question again.
So second question, in terms of knowing what you know now from your data, did your theatre staff or department change the way in which they cleaned the theatres prior to every patient? Were there any changes that were made during that time in April when you collected the data?
Yeah, so our sort of operating procedures have changed multiple times since March. At the very start, then basically, if you were suspected of COVID, then you wouldn't go for an operation until you had a negative swab. And the reason for that was because we had the clean theatres, and then we had the COVID theatre. Operating in COVID theatre meant that you weren't operating with orthopaedically trained staff, so you'd end up waiting ages and ages for any implants that you needed. They weren't trained to put the drill together, things like that. So sure. Logistically, it meant that, for example, a 1 hour procedure would take 4 hours. that was the kind of downtime that they were working with. So the orthopedic department made a decision very early on. If you were query COVID, you didn't get an operation until you were not COVID, and if you were subsequently COVID, then an operation wasn't the answer.
And in terms of looking at those patients who had a prolonged operative time, apart from death and COVID-related issues, did they have more 30-day comorbidity compared to the patients that were, that you compared to your previous data set?
Actually, that's something that we would have liked to have looked more at, is the morbidity, but we were really mainly looking at mortality. Actually, the length of stay in the 2020 cohort compared to the 2019 cohort was significantly shorter. We were getting people discharged, like the ones that were discharged, we got them discharged much sooner. I think it was like 10 days and 6 days even. The averages. So, but we didn't look at the morbidities.
Thanks.
Okay. Any questions from the floor? Can't see any there. So what we'll do is I'll send our judges and Thomas off. Thank you very much for that. Right, Carolina, are you back? Okay, we've got this. Everyone cross everything.
Hello?
Yeah.
Yay.
Fantastic. Okay.
Fantastic. Right, let me see if I can do...
Now the screen sharing.
Now the screen sharing. Exactly. Hang on. Let me just see. Aha. And we may be winning.
Brilliant.
Is that all working?
Oh, smooth. Okay.
Perfect.
Are you happy to start?
Yeah, absolutely.
Go for it.
I mean, I never really envisaged, presenting at a conference from the comfort of my living room, but I think a lot of clinicians have found that, they're quite surprised how many virtual clinics they're now doing. And so I'm just going to talk to you a little bit about how I think virtual clinics are probably here to stay in some capacity in the context of a voice clinic that was set up at Guy's. So COVID has meant that we've needed to kind of work in new and innovative ways. And I think the demand for virtual platforms such as this one has never really been greater. And at Guy's, they set up a voice clinic via telephone and a video. So we just wanted to ask a few main questions really about the virtual clinic. Firstly, are they effective? So are they as effective as your bog standard face-to-face clinic? Do patients like them? So, are people prepared to get on their laptop, get on their smartphone and speak to a specialist consultant via that platform? And then taking those two things into account, should we, fingers crossed, when COVID kind of peters out, should we be kind of, using this going forward? So we basically looked at all the virtual clinics that we did in May of this year and compared that to your kind of standard clinic in November of last year. And I think the first thing to note is that we saw 155 patients in May versus only 70 in November. So huge kind of increase in capacity to see patients. And then we kind of compared the outcomes. So quite comparable outcomes of patients kind of referred for diagnostic imaging, referred to other specialties, quite a considerable number prescribed medication virtually and referred to a virtual speech and language therapy. In terms of discharges, we thought that clinicians might be a little bit hesitant to kind of discharge people without seeing them one last time. But we actually saw that there's only 6% fewer patients that were discharged from the clinic. But the biggest difference was the listing for the theatre. So in November, 14% listed for an operation, and in May, less than 1%. So obviously, quite significant, really, difference there, probably due to the lack of examination ability, obviously, from a. So then we did a patient survey. So we called all the patients that we saw. We managed to speak to 75 patients, huge age range, as you can see, and about 3/4 of which had a telephone consultation and 13% video, and the others weren't really recorded. About a 50-50 split between new consultations and follow-up consultations. And we basically asked them lots of questions on you know, were they satisfied with it? Did it meet their kind of health needs related to their voice? And would they want the option of virtual clinics in the future? And kind of facilitated a bit of informal conversation around those questions. So what did they say? So 98% of people said that overall they were really happy with the virtual method, and a lot of comments of, you know, they're actually surprisingly impressed with the system and it was smooth, it, you know, saved them so much time. 60% said that they felt the consultation was adequate in addressing all their health needs related to their voice. Now, there is a bit of disparity here, and I think when we spoke to patients in a bit more detail, you know, a lot of them were like, oh, we were really happy with how it all went, but actually I'm still needing a flexible nose endoscopy or laryngoscopy. So, you know, 84% still felt that they would need, you know, they would benefit from an in-person kind of physical examination. But having said that, you know, nearly 3/4 said that they prefer to have had this virtual consultation rather than, you know, waiting potentially months for a face-to-face appointment. And over 80% said they wanted the option of a virtual clinic in the future. We did a bit of subgroup analysis, and that was actually very comparable across all the age groups. So your 80-year-old lady was actually just as happy to get on the phone as someone in their 20s, which I found quite surprising, actually. And comparing kind of new consultations and follow-ups, as kind of expected, people having follow-up consultations were a bit happier to have a virtual method than those having their initial consultation. So I think there definitely is a place for them in the future, but probably with a few caveats. I think the main thing that we got from the study was that the majority of patients had a very, you know, overwhelmingly positive experience, and we kind of showed that you can progress with diagnosis and management to a degree, and obviously listing for operation is one of the things that slightly hindered. It doesn't suit all patients. I think there was a couple of groups that we identified, you know, people with cognitive decline, people with autism, you know, people whose voice actually wasn't good enough to speak on the phone. It didn't suit them. I think you might be thinking, you know, how on earth can you conduct a voice clinic without examining somebody or looking at someone's vocal cords? And I think that's definitely true. But lots of these patients are having follow-up clinics, they're having post-op appointments, and that kind of does lend itself potentially to a virtual platform. I think lastly, I think what came out of this quite strongly is people don't like to wait. And I think COVID is, you know, not unique in that sense. You know, we've got crises with waiting time, people waiting months or years to see a laryngologist. So, you know, it might have a place there. So, you know, with all the challenges we've all faced in the last couple of months, you know, we've managed to work in an innovative way, even for a voice clinic, and there's so many positive things that I think have come out of it. You know, from reducing travel times for people who live far away to, you know, reducing DNAs, and actually, you know, also I think can't be underestimated, giving us the potential option of working from home, which I think none of us really thought was, you know, on the cards, so to speak. So I think, you know, other specialties have used it in some capacity previously, and I think we are going to see, you know, widespread use of virtual clinics in some capacity. And I think it's just, we need to appreciate its limitations, and the obvious one is obviously physical examination. And I think if we use it in the appropriate context, you know, potentially for follow-up appointments or, you know, an initial kind of triaging type appointment, you know, it might work really well. And I think patients like being given the option, and I think, you know, speaking to a lot of these patients, you know, they really, you know, they're very happy and very open, more open than I was anticipating, actually. And a lot of them, majority, wanted the option of having a virtual consultation in the future. So, thank you very much. Happy to answer any questions.
Thank you. I hope the judges don't mind, but I'm going to start with a question, if that's okay. We've been doing this where I'm working, and from our 75 to 100 patients, we found that some of the older patients are actually not enjoying it. Do you think there are potentially groups that we're missing out on here because of do not attend and being unable to follow them up and find out what their opinion on this is?
Do you mean the do not attend in terms of people that you weren't able to have the virtual clinic with?
Yeah, because obviously we can only get feedback from those who've been able to have the clinic or agreed to having one over the phone.
So I think the focus, for most people was, to be able to do a virtual clinic for those that are able, and, for the most vulnerable patients who need to be seen in person, they were seen in person. So sure, we've only got a specific cohort, but actually among those patients that we did see, we had quite considerable numbers in that older age category, so in their 60s, 70s, 80s. And I was actually really surprised, hearing people who are, they're shielding, they might live 2 hours away from London, and they're actually, a lot of them are a bit more tech savvy than I think some of us appreciate, and actually they really enjoyed it. And I was expecting to see a disparity between young and old, and to be honest with you, there was very little difference with how they kind of got on with it and their, how happy they were.
That's interesting that you found a difference there, and I think in time we're going to get.
Yeah, for sure.
Throw this out to Darren for the next question.
Hi, Carolina. Thanks for your talk. First question is, in terms of the video calls, what platforms were you using and how secure were they?
So gosh, I can't remember the name of it's a specific video platform. I can't remember the company that we use at Guy's. I can't remember. But if I have to, 3/4 of the calls were actually via telephone. Okay. And actually, yeah, so the vast majority via telephone and a smaller number via video. I think there was a little bit, in terms of the platform used, I think there were a few technical glitches sometimes with the video where people would start with video and then have to convert to phone. And I think that kind of, comes with some of the teasing problems of this whole system. And I think, going forward, if we were to use telephone and video, we probably would have a slightly slicker, mechanism of people choosing which one they want and going for, so that it's more effective. But I honestly can't remember the company's name of the platform we use at Guy's. Sorry about that.
No, that's all right. The other thing is, I think you hit the nail on the head in terms of patients don't actually like to wait. So hence the video calling and the virtual clinic sort of answers that question in terms of not having to wait as much as they would physically in clinic. But as we know, surgery is a very palpation orientated type specialty. And my feeling is that seeing new patients this way may have some medical legal issues compared to looking at them using this platform for looking at follow-up patients. So post-op patients that don't really have to come in, you can ask them basic questions. So you didn't find, like, for example, your news versus your follow-ups, there was a disparity in their satisfaction rate, that they would have rather seen someone as a new patient and rather be followed up as a virtual?
So there was probably about a 10% kind of disparity, I would say. And I was actually very surprised. I think a lot of the patients that were seen as a new consultation, firstly, they were very grateful to not have to wait months and months and months to be seen. And they kind of were happy to get the ball rolling in some ways. And I guess in a kind of triage sense, clinicians could kind of say, what kind of a problem is this? And, if it sounded like something that it was reflux or whatever, they could be started on some Mrcs, they might be referred to a voice clinic, and they still were going to be seen in person. I think the trouble is the duplication of work, and I don't think you want to end up having, a virtual appointment consultation with somebody, knowing that you're going to need to see them in person anyway, and kind of probably go through the same questions all over again. So in my view, I think the follow-up, side of things is where it's going to work better. But actually, I was surprised that patients being quite satisfied, actually, even for a new consultation. I thought that the disparity would be larger, but actually, the 74 patients, there was actually little, 10%, but it's not much.
Fine, thank you very much.
Luke, I just unmute you, go for it.
Great. I actually have two questions. And the first question is about you undoubtedly have shown that there's been very high satisfaction with the telephone and virtual clinics. However, do you have a control group who know what the people who come to clinic are thinking? Are the people who come to clinic, are they equally 80% happy? Or have you felt there's just a difference and they're more happy than the people that come to clinic?
So we don't in this study, we don't have a comparable test from the in-person clinics. That'd be useful and interesting to look at. But we don't have a control group for this, no.
Cool. And the other question I have is about the primary outcome of a clinic appointment should be sort of the quality of the appointment. And if there's sort of 1% of people being listed for theatre with a virtual and 13%, are you concerned about the quality of appointment, that actually that there may be things that are being missed? I mean, surely that people are bringing people back for examinations and for more tests, but actually if there is such a disparity in people being booked for operations, there may be a disparity in the quality of appointment.
Sorry, I couldn't quite hear that, but I think I've got your question. I think for the majority of people where they may eventually be listed for theatre, the plan was to basically get them back to have a flexible nose endoscopy, to have a look at their vocal cords and then list them. I mean, obviously no one's going to list someone for a pan endoscopy or anything like that without having a look. I don't know. I think it's difficult to say, whether we're missing things, but I think for the majority of patients, the plan and the kind of outcome is to get them back and examine them. And I think it's difficult to say, but you would hope that things are not being missed. And I think the pathway of how things were set up to get people back to examine, I think is hopefully not the case.
Cool. No, good. Really good project. Pretty good.
Thank you.
Thanks, Carolina. So we'll try Bryony now.
Right. Hopefully this time it should work.
Okay. Yeah. So just to remind everyone, Bryony will be presenting her work on triaging patients with COVID-19. Have you shared your screen?
I've clicked share, but I'm not seeing it.
Okay. Again. You want to email it to me?
Yeah.
And then I'll
email address, I'll send it over.
Yeah, you send it over and we'll bring on the next person. So that'd be Deepak Menon. Fantastic, Deepak. Very quick there. Deepak, nice to see you again. Hopefully this runs smoothly. So Deepak's work is titled COVID-19 Pandemic on Mental Health in Healthcare Workers, a Single Center Perspective.
Thank you.
So whenever you want to start, you just crack on.
Grant, are you seeing the presentation?
Yeah, looks great, and I can hear you really clearly.
Excellent. So good afternoon, everyone. My name is Deepak. I'm a core surgical trainee currently in the Yorkshire Deanery, and I'm part of the team which looked at the impact of the COVID-19 pandemic on mental health in healthcare workers at Scarborough General Hospital. This is essentially an overview of our work, and I'll just quickly go through the backgrounds and methods involved, present our results, and just highlight some key discussion points that we've identified from this project. So coronavirus or COVID-19 has caused over 10 million confirmed infections and over 500,000 deaths worldwide. But alongside this profound impact that the virus has had on physical health, the impact of the virus will have a huge impact on the world's mental health as well. And evidence from previous epidemics such as SARS and MERS have shown that actually they have a disproportionate effect on the mental health of healthcare workers in particular. And this is the evidence already bearing out this pattern for COVID-19. This particular study by Lai et al. From China report that over 70% of healthcare workers reported psychological distress and 50% reported symptoms of depression. So with all of this in mind, our study aims were to determine whether the current COVID-19 pandemic is affecting the mental well-being of healthcare workers in our hospital by measuring the levels of stress, anxiety and depression amongst healthcare workers. Our secondary aims were also to assess the adequacy of senior support, whether there was any impact on training, to assess the availability of PPE and the utilization of staff well-being measures during this period of time to identify any possible contributing factors. So to achieve this, we constructed a questionnaire that was based on the Depression, Anxiety, Stress Scales questionnaire, also known as the DAS questionnaire, allowing for an objective measure of depression, anxiety and stress in all individuals that took part. And further questions were included based on our secondary aims as shown here. And this was distributed to all staff members within a 2-week period in our hospital and wasn't a survey. So what did we find? Well, we got 69 responses in total. And from a demographic perspective, 27.5% were doctors, 29% were nurses or care practitioners, and 42% were allied health professionals. And from this, 36% of respondents reported depressive symptoms, 43% reported anxiety-related symptoms, and 30% reported stress-related symptoms. And as an aside, there was no statistically significant difference that was reported between depressive symptoms in doctors or the nursing staff relative to all other allied healthcare professionals. Now, with respect to our secondary outcomes, 25% reported an inadequacy in the availability of staff wellbeing resources, 10.1% reported an inadequacy in the degree of senior support that they received, and 9% reported an inadequacy in the availability of PPE, with no significant relationship reported or identified between depressive symptoms reported and these secondary outcome measures. With respect to the impact on training, there was a significant relationship, with 59% of respondents reporting that their training had been adversely affected and was therefore considered inadequate. So what does this all mean and what can we take away from these results? Well, the rate of depressive symptoms reported in our centre was about 36%, and this remains quite a concerning figure, particularly in association with the high levels of anxiety and stress that were also reported by staff members. We identified a number of contributory factors. So firstly, given the long-standing and highly publicised issues regarding the availability of PPE, this no doubt is a source of psychological stress for employees, but our results suggest that there wasn't really a significant impact between PPE availability and depressive symptoms, which is probably a reflection of local variance in equipment availability. Secondly, we know that shared trauma can bring teams together due to increased communication. For this to happen, teams need to be well led and there needs to be good senior support. And actually our results do suggest that most or a large proportion of those that were questioned do feel supported by their seniors, and it's supported for this to continue into the future. We suggest that there is probably a link between impact on training and the depressive symptoms that were reported, and so the detrimental impact of the virus on professional progression probably does have a negative impact on mental health, acting as a key psychological stressor. And finally, a large proportion of respondents reported that the availability of wellbeing resources was inadequate. But when we, the proportion of those that answered the survey actually, a large proportion of those that answered the survey hadn't actually accessed the staff wellbeing support webpage, 52% in fact, which suggests that actually this low perceived adequacy was probably due to low utilization rather than the low quality of resources available. And this might be because of a lack of awareness or a lack of willingness of staff to actually discuss their own mental health. So in conclusion, we found that the COVID-19 pandemic is exerting a significant mental health burden on healthcare professionals. We identified a number of key contributory factors, including impact on training, and a lack of uptake of staff wellbeing support measures. And going forward, future aims would include to ensure that adequate PPE is available to protect physical well-being, that appropriate leadership and support continues to fulfill training needs, and to ensure that there's active or proactive provision of targeted training tools to improve mental well-being. So many thanks for listening, and I'm happy to take any questions for those that have them.
Thanks for that, Deepak. We'll bring on the judges now. If there's any questions from those watching, please do. Nice to see that we're all still here. And Brian, if you just send that email over, I'll try and get you up a little bit later in the session. But we're doing well. We're nearly there. Bring Luke, Darren on. And we'll start with Darren this time.
Hi, Deepak. Thanks for your talk. It's very interesting. One question, really. I mean, let's not get this wrong. Our jobs are already quite stressful as it is, with or without COVID. So in terms of assessing these assessing the doctors and allied healthcare professionals in terms of looking at their depression and anxiety, did you take into account those that already had pre-existing anxiety and depression before measuring the absolute anxiety and depression through your forms?
No, so that's probably one of the key limitations in our study, to be honest with you. So it was just really a snapshot project during that 2-week period. Ideally, what we would like to have done was do this project before the COVID pandemic, do it during the COVID pandemic, and then do it after the COVID pandemic to see if if all of the data was actually relating to the current situation with respect to the epidemic. Unfortunately, we don't have that data available, and that's probably is the key limitation in our work and in our data collection.
Thanks very much.
I've just got a question about the well-being. You said that 52% of people did not access the well-being website, which means that 48% of people did, which I found incredibly high. And the question is the well-being website really the answer to well-being of doctors, or is there something else that we could be doing, i.e. spaces or more time off, or access to counselling or something like that?
No, I absolutely agree. I don't think the website or just a website in isolation, probably it doesn't have any impact really on relieving stress and mental well-being. It might just be a tool for local trusts to say, actually, we recognize it's an issue, and it might be a way of flagging up other resources that people can use, or identifying probably more important and pertinent ways to get support, whether that be through counselling, identifying mentors, things that advice forums, and engaging with staff. So I don't think it is a solution, and it's probably quite understandable that 52% of people didn't access it. I personally didn't access the staff wellbeing website as well. I think it just highlights the fact that we probably could do more, but that's not to detract from the fact that actually trusts do recognise that this is an issue, and it should be more heavily advertised.
Right, I think a lot of the stuff is cast on the person who's then having mental health problems to try and come forward, when it should be the other way around. CP are virtual at the moment. My training program director doesn't even see me once a year to say, "Are you okay? Is things going okay?" So it's very rare that you even have somebody come to you and say, "Are you okay? Is your training going fine? How are you getting on with COVID?" And there haven't really been any sort of checkups on trainees, as far as I can be aware, to find out if I was having mental health problems, because it seems on the onus on the person who's suffering to come forward and say there is. But really, from people, we should be having more senior doctors and people within our hospitals coming to check up on us and say, "Are you okay?" So it's a really good project.
Yeah, thank you very much. Probably reflects the importance of leadership as well, the importance of education supervisors, people of that nature as well.
Darren, any last comments?
No, that's it. Thank you very much. Thanks, Deepak.
Fantastic. Right. Bryony, I've got your slides ready. So why don't you come back on?
Right. Hopefully this time we'll be able to see slides.
Okay, sorry, had a little issue there.
Perfect.
So everyone should be able to see that. Can you see that, Bryony?
Yes, I can as well. Yeah, no, that's great. Thank you. Apologies for the technical difficulties. But yeah, my name is Bryony. I'm a core surgical trainee currently working in general surgery in the Oxford Deanery. And this is a project that we did looking at different support tools that could be used to triage patients with COVID-19. So yeah, if you go to the next slide, that'd be great. So as I'm sure we can all remember, back in March of this year, we were anticipating a surge of inpatients with COVID-19 in the UK. And looking at various other countries such as Italy and China, we could see that there were potential concerns about limited resources, specifically sort of availability of ICU beds and also other hospital resources such as oxygen as well. Next slide. And so on the 20th of March, NICE released a COVID-19 guideline, which suggested that on admission to hospital, all patients should be assessed in terms of frailty using the clinical frailty score. And NICE had suggested a cutoff of 5. So any patient with a score of 5 or more should be considered for critical care and for ICU. Next slide. This is the clinical frailty scale. So for any of you that aren't aware of it, the cutoff between 5 and 4 is between vulnerable and mildly frail. So patients that were deemed to be mildly frail would be patients that needed help with higher order activities of daily living. Next slide. So in late March, the NHS released a COVID-19 decision support tool. So this wasn't formally released, it wasn't part of a guideline as such. And it was essentially initially sort of leaked via the media. There were a lot of media reports of this decision support tool. And essentially it includes the clinical frailty scale, but also includes age and various comorbidities as well. And with this decision support tool, it was advised that anyone with a score of 8 or less should be considered for ICU-based care. And so what we did was to look at both of the clinical frailty score and the decision support tool. And we also looked at age as well, and how these different support tools act as systems to triage patients, both in terms of their outcome and in terms of mortality, but also in terms of their ceiling of care decisions that were made by the medical teams. So we did this by looking at all patients that were admitted to Oxford in a 2-week period in April that were found to be COVID positive. We identified these patients. There were 2 ways. So one cohort were patients that ICU had reviewed. And then we also found that there were some patients that weren't reviewed by ICU, either due to the fact that they were too well to be considered for critical care support, or that they were deemed by the medical team to be too frail to be considered for ICU. And we had 2 data collectors review each case independently on our electronic patient record system. And we subsequently re-reviewed any cases to make sure that there were no discrepancies. Next slide. So these were all the different data criteria that we collected for all patients. Actually, it was every aspect of the decision support tool, and then also looking at that outcome as well. Next slide. So we found that actually a majority of patients in that 2-week period were reviewed by ICU. So 78 patients were, and then 44 patients for various reasons were not reviewed. Next slide. Thanks. So this is a histogram looking at the decision support tool. So these patients could have a score from anywhere between 1 to 19. And according to the decision support tool, anyone with a score of 8 or less should be considered for ICU. But we actually found that there were some patients that had a score as high as 12 being admitted to ICU. But as expected, the higher the score, the less likely you were to be admitted to ICU. And when comparing that with the NICE clinical frailty scale, again, we found that this was slightly more specific. So this one, it's a scale of 1 to 9, and it's anyone that's got a score of 4 or less would be considered for ICU. Again, we found that there were some exceptions to the rule, so some people with scores of 5 or 6 being admitted, but in general, the majority of people who had a score of less than 4 were being admitted to ICU. And then this is looking at the age distribution amongst the ICU admissions, and it's generally quite varied. And we were surprised to see that there were patients that were sort of in their 80s being admitted to ICU. And so I guess that's sort of one of the factors of both taking into account their age and clinical frailty score and comorbidities in the decision support tool, whereas clinical frailty doesn't take age into account. And so the next histogram is looking at outcomes of these patients. So we looked at this at the end of May is when this screenshot was taken. And so at that point, you can see that everyone that had a score of 10 or above, unfortunately, did die. But there were some patients that had a score of 9 who were discharged home. So the majority of patients that had a score of 9 were discharged home. And actually, there was a significant proportion of patients who died that had scores of 7 or 8. And when you compare that with the NICE clinical frailty score, actually the cutoff point was fairly specific in that everyone that had a score of 5 or more actually, unfortunately, did pass away. And the majority of patients with a score of 4 or more were discharged home. And then the next one, this is looking at outcomes according to age. And again, the mortality rate was quite spread. So a score of 1 would be anyone under the age of 50, going all the way up to 7, which is anyone that's 80 or over. And the mortality rates were spread throughout the age groups as well. So we plotted a receiver operator curve here to compare all 3. So the decision support tool and the clinical frailty score and age as well. And anything that's above that red horizontal line is considered to be an effective predictor, a tool for predicting. So this is specifically for mortality. And we found that the decision support tool was more predictive than the clinical frailty score. And I think that's to be expected given that the decision support tool considered more factors. You know, it was considering both age, their frailty score, and their comorbidities as well. And then interestingly, when we compared all 3 to look at the prediction of clinical decisions, so looking at who had a ceiling of care placed as an ICU level, we found that there was considerable overlap. So looking at the curve, that all 3 were actually fairly useful tools in predicting a sort of level of care, but there was considerable overlap between the clinical frailty scale and the decision support tool. The numbers were fairly similar. Next slide. Interestingly, we found that there were some cases that were outliers. So these are a couple of patients who were in their 40s, had fairly low clinical frailty scores, that had their ceiling of care capped at non-invasive ventilation and not for ICU. And we found that this was because of other comorbidities that weren't included in the decision support tool. So one of them was diagnosed with TB and HIV during the admission. And then the other patient had a long psychiatric admission, and it was documented that they felt, the ICU consultants felt that if she were to deteriorate, it wouldn't be in her best interests to intubate her and ventilate her. So I think it's an interesting case of how, whilst these decision support tools are useful, clinical judgment also prevails, and there will always be outliers to these tools. And obviously, in study there are limitations. So our cohort was relatively small, so we're currently looking to expand that. So this data is all from a 2-week period in April, and we're currently expanding it to all patients in April, May, and June. And so we're, and also we also found that so ICU were including COVID syndrome patients. So these are patients that aren't COVID positive on PCR, but clinically and radiologically are acting as COVID, so considered COVID syndrome. However, our non-ICU reviewed patients were only patients that had a COVID positive test. So next slide. So as I said, the next steps that we're currently doing is we're expanding the patient cohort and also including COVID syndrome patients. So yeah, happy to take any questions.
Okay, let me just come back here, bring the judges on. Brilliant. Well done, Bryony. Darren, do you want to kick us off?
There's a bit of an echo at the moment. I'm not too sure.
Darren, do you want to do the first question?
Yes, that's fine, but there's a bit of an echo. Is it echoing on your side?
It's okay here.
Okay. Thanks, Bryony, for your talk. Just a couple of questions. So in the early part of the presentation, you said there were some patients that weren't reviewed by ICU and there were various reasons. I'm not going to ask you for all the reasons, but what were the main reasons why these patients weren't reviewed by ICU?
So the majority fell into two categories. So they were either too well, so some patients were coming in literally just for sort of oxygen support, mainly capped at sort of nasal cannula level, not requiring critical support. And then there was another cohort of severely elderly patients where it was sort of clearly documented by the medical team that they wouldn't be for ICU. And so that decision was made by the medical team.
Okay, thanks. And the second one was in terms of looking at the decision support tool, was there any avenue to input the symptoms that these patients had in terms of prognostication, or was it just based on age and comorbidities?
Yeah, no, it was just based on age and comorbidities. It's a fairly significant list of comorbidities, but no, it wasn't looking at the patient's symptoms on arrival, no.
Okay, all right, thanks very much.
A question about the of the decision support tool. Is this something that was reviewed afterwards, i.e. they decided to take them to ITU or not take them to ITU and then looked afterwards, or is it being reviewed on the ward and saying decision report tool score is 6, they can go, 10 can't go?
So it wasn't formally introduced in Oxford. It was something that various clinicians were using as a tool, but it wasn't universally used amongst the ICU department, which is why we did this project, and then subsequently the ICU department are now considering using it routinely. But it was mainly used as a sort of a triaging system. So the medical team would refer to ICU, and ICU would normally come down and review them and then document their DST score, say for various reasons this patient wouldn't be for ICU, and it would be an additional kind of factor to support their decision.
Frailty score, a knowing use score, and the decision for you to improve the frailty score. And if you do that, is there a possibility of just muddying the waters a little bit?
The audio cut out there. I think I understood your question. So the frailty score is a universally recognized clinical frailty score, and it's the same frailty score that's used in the DST. So NICE recommended to only use the clinical frailty score alone, and then the decision support tool uses that in addition to both their age and comorbidities. I'm not sure. I missed the other half of the question, so I'm not sure if that answered it entirely.
That does answer. But I'm wondering whether by creating more tools that are nationally standardized, it may be just some more jargon for the ICU team to have to sort of keep up to date with.
I think that's a really fair point, to be fair. And actually looking at the results in terms of predicting a level of ceiling of care, we actually found that there wasn't that much difference between the frailty score and the DST. It's sort of interesting how it came out. It was sort of leaked to the press, and there was no formal release of it nationally. The NHS released it, but there was no formal kind of release to all hospitals in terms of the guideline. But I think it's a useful factor because it takes into account multiple things rather than just the frailty score.
From Darren, so go for Darren.
Yeah, thanks. I was just going to ask in terms of sensitivity and specificity of your tool. Like, did you find that it was actually quite spot on in terms of the patients that you stratified and were, predicted to have a poor prognostic outcome? That's the first thing. And the second thing, those that were deemed not for ICU, who were scored using this tool, did some of them make a positive recovery?
So in terms of outcome, I can remind me. There were, so from memory, what I can remember is there definitely were some outliers in terms of patients that had very high ICU and subsequently were discharged home. But those were very few, were sort of literally outliers. The majority of it tend to fit to the sort of direction of the scoring system.
Perfect, thank you.
Fantastic. Thanks, Bryony. Really interesting. I'm sure that as we see further COVID cases, we'll have more work on this. Okay, so next, I believe, is Thomas Riley. Well, I'm bringing him on either way. Let me just double check. Perfect. So only 2 more to go, and they've been fantastic so far. Hey, Thomas.
Yep. Can you hear me?
Yeah, perfect. So Thomas's presentation is titled "Impact of Redeployment on Core Surgical Trainees During COVID-19." So this is obviously very close to all of our hearts. So let's see what you found.
Okay, so I'll share my screen now, yeah?
Yeah, go for it.
Okay. Okay, can you see that?
Yeah, brilliant.
Okay, so good afternoon. I'm Tom. I'm one of the Northwest trainees, and this project is on the impact of redeployment of core surgical trainees during the COVID pandemic. So a bit of background, first of all. The COVID pandemic has necessitated a rapid, widespread redeployment of the medical workforce into areas of anticipated high clinical need, such as intensive care, general medicine. The Academy of Medical Royal Colleges released some guidance in March, which essentially highlighted the need for formal training prior to redeployment and prior to patient contact for these redeployed trainees. So the aims of this project were firstly to assess the extent of core trainee redeployment, to assess the training provided, and to assess the impact on trainee well-being. So we did this by disseminating an online survey via email to all of the core trainees in the north of England. This was timed to coincide with the peak of the pandemic in April from the 1st to the 14th. And then there was a 3-month follow-up survey in July, also live for 2 weeks to get the full picture of what happened throughout their redeployment. So all core surgical trainees were included, all non-trainees and higher surgical trainees were excluded. So 327 core trainees were contacted, 135 responses, giving a response rate of 41%. And each region contributed significantly to that total number. So there's a few graphs coming up. This first graph looks at redeployment status, and this is specifically looking at the first survey. So during the peak of the pandemic, we can see here that 41% of trainees had not been informed at this point whether or not they would be redeployed. And this was an area that was highlighted that trainees were dissatisfied with because they don't feel they were given adequate time to prepare. We can then see that nearly 50% of trainees during the peak had either already been redeployed or were awaiting a planned redeployment, and 11% had been told that they were going to stay in post. Now, looking specifically at those 35 trainees that had already been redeployed, we can see that the commonest areas were critical care, general medicine, and dedicated COVID wards, as you would expect, with smaller contributions to A&E, other surgical specialties, and respiratory medicine. Now, looking again at those 35 to see whether or not those redeployed trainees had any teaching, any formal training organised by the deanery, the trust, or by the local department, 40% said no, they'd received nothing. 37% had received training. Nearly 10% had training planned but had not yet received this. And another 15% missed this, either due to work commitments or needing to self-isolate. So that's a total of 54% had neither received training nor were about to receive any training. And on top of that, 48% reported they were unaware of any self-directed training materials. So with regards to safety, you can see that during the peak of the pandemic, when cases were highest, only 56% of the trainees had been trained to properly, formally don and doff PPE, and only just over 2/3 had been successfully fit tested for an FFP3 mask or respirator. Now, we asked trainees about perceived preparedness, and now this is looking at the total cohort, so either preparedness for redeployment or potential redeployment. and just 15% of the respondents reported that they felt prepared. Around half felt partially prepared, and just over a third felt unprepared. And there did seem to be an association between preparedness and whether the trainees have received teaching. So in that prepared group, 45% had received teaching, partially prepared 35%, and unprepared just 13% had received teaching. But due to the small sample size, this didn't reach statistical significance. Now, the follow-up survey, 3 months down the line, the same respondents were recontacted, and 36% responded to the follow-up survey. Salient points from this were that less than half of those trainees who were redeployed actually received any formal induction at any point, and nearly a third of them had mentioned that they had been asked at some point throughout their redeployment to work beyond their perceived level of competency. Now, with regards to well-being, around 50% worried about their own health, 3/4 worried about passing the infection on to family and friends, nearly 2/3 reported low mood, and 61% heightened anxiety. That's compared to baseline. And one trainee reported accessing psychological support services as a direct result of having worked during the COVID pandemic. Now, in terms of limitations of the study, we're only here looking at core surgical trainees, so we've not taken into account higher surgical trainees or non-trainees. And the other thing wouldn't have captured here would have been the fact that there may have been some excellent high-level informal teaching given on the wards, which was unmeasured. However, this was specifically just looking at formal teaching. The other thing is that whilst the response rate is reasonably modest, it's not out of line with what you would expect for a web-based survey, it's still less than 50%, so survey fatigue could have been an element here, and that could essentially lead to an element of response bias. So in conclusion, there has been a high rate of redeployment. I think that the safety measures, particularly with regards to PPE and donning and doffing and FFP3 masks, have been inadequate. Although we did identify some good examples where trainees received multiple modalities of teaching and felt prepared. On the whole, generally there was limited COVID-specific induction and training, and there was also a marked impact on trainee well-being. So why is this important? The UK at the moment, cases are soaring. It seems as though an imminent a second wave may be imminent. So this is a golden period, this hiatus between now and a potential second wave with which to rectify the initial problems with redeployment in the first wave and help us to care essentially better for our trainees and for the patients. So any questions?
Okay, thanks for that. Really interesting stuff, and obviously really you've got a crowd who's keen to listen to this information as we've all been through it. I also found myself on an intensive care unit, and one of the other committees has actually been on intensive care all year. Luke, why don't you kick us off?
Yeah, so I just wanted to ask about the potential benefits in terms of your training of being in intensive care. I know some core surgical training rotations do involve intensive care.
Sure.
Has there been any feedback, sort of positive feedback in the skills that have been learned and maybe will be moved forward? Because a lot of the stuff seems to be sort of negative about being redeployed. Has there been, has there been much sort of positive feedback?
Yes, there was actually. So from trainees, we asked specifically about essentially the negatives and the positives. So we found that 98% of people were getting less or no surgical training. Around 30% got no surgical training. But on the flip side, it was around 20, in the order of about 20% did say that through being redeployed to intensive care, they'd picked up skills that they wouldn't ordinarily receive. Some people were unable to do things like central lines, as you may not do doing unless you've done an intensive care project, and came out of that able to do central lines, arterial lines. Nobody was really taught to intubate patients because it was done by high-level teams in most units. But there was a proportion of trainees who did actually find that beneficial. However, there was, I think, the overall picture was that of a negative impact on training, even taking that into account. So the majority of people are saying that there's a really significant impact on their potential career progression. People were worried about their progression, worried about their operative ability, and I think that overall the feedback, the picture was that did outweigh the benefits of the added experience in the critical care setting.
Yeah.
Okay, Darren, go for it.
Thanks, Tom. Quick question with regard to the 40% of trainees that didn't get training that you showed earlier on in your presentation. So were there any reasons as to why they didn't get the training? Was there anything in particular with regards to departmental setup? They didn't have enough staff, they were too busy. What was the reason? It's quite a high number.
Yeah, no, it's a high number. And that number was also even higher in the non-redeployed trainees, because we also asked the question, are you imagining that you are going to be involved in the care of COVID patients, given that there's a significant number of patients, in my experience anyway, on urology and general surgical wards, and the amount of training was even lower if you were non-redeployed. However, you were still expected to then provide care. There weren't, in the feedback, the reasons that were generally given were just not enough manpower, given the fact that there was a late redeployment, and that's why people were quite dissatisfied. Around, as I said, around 41% didn't even know that they were going to be redeployed or not when the cases were highest. So I think it was a case of we've not seen this before. It required massive organisation, and it's rapid workforce planning. It's balancing that at the same time as having a huge caseload where all of your senior clinicians who would normally provide that teaching are now otherwise occupied on the wards, actually managing on the shop floor the crisis. So I think that the biggest point was an organisational difficulty to actually get trainers in there.
Thanks very much.
That was fantastic. How would you redeploy all the trainees in a second wave?
So I think the key thing, this is something, I went to intensive care myself as a trainee and spent around 2 months there, which I think was the average from what we've got from our data. My problem was I wasn't told until roughly a week before. There was 6 weeks worth of us saying, we don't know where you're going to go. There was minimal training provided, and the only training that I got was self-directed things that I found myself, and luckily my deanery also provided some training. I think the crucial thing is telling people early and having a plan. We know cases are going up now. There's no reason now why we've got this data, and this data should be available in multiple different regions. And it's not just core surgical trainees that will be redeployed. There should be a plan in place now to say to certain groups of people in certain roles that if this escalates, you will be redeployed. This is where you'll be redeployed to, and start the training now in the hiatus prior to redeployment, so that people are aware and people are then more. I think the key thing is, during a crisis like that, you don't want your senior clinicians having to essentially babysit people who've never done any critical care before. You need them to have a certain baseline level of knowledge, even if it's time shadowing in ITU, just knowing the processes of how to get through the ward round quickly and efficiently, so that they're not constantly being required to come in and do every single job. So I think one of the key things would be time shadowing in ITU. We only saw 10% of people. This was of the whole cohort. It's not just the people that went to ITU, but only 10% got shadowing in ITU beforehand. And I think that's invaluable just in terms of the smooth day-to-day running of a ward round, and freeing up senior clinicians to then be able to do their own job and manage from a more senior position.
And is it our responsibility, or should ITU and our anaesthetic colleagues be helping?
I think there's a joint responsibility, really. I don't even necessarily think it's surgeons and critical care. I think it needs to be a trust and higher level as well, to say, we know where you're going to go. We're going to put into place a plan to get you through smoothly and efficiently, and also to then signpost people towards self-directed learning resources. So I think mainly at the trust level is the key, and then the trust should coordinate between the different specialties to ensure that there are training in process, and that there's shadowing, so that when you turn up, like I did on my first day, having never worked in ITU before, in the middle of a pandemic, not knowing how the ward round performers work or any of the other day-to-day running, then I think those are simple things that would be easily rectified now, which are going to be much more difficult to rectify, say, in 4 weeks' time, if there's a second peak, which is far worse than the first peak. And it would be silly for us to land in that same situation, knowing now what we know, and knowing that actually it was reasonably poor, the amount of training that we gave to redeployed trainees. I think it's a foreseeable issue now, and there are clear things that we can do to rectify that.
Yeah, I didn't realise how important learning the alphabet was when I was doing an A to G assessment. Any other questions from the judges?
No, that's it. Thank you very much.
Thank you.
Okay, fine. We'll go on to our last one. Everyone's been fantastic so far. Great session, so bear with me. It is Sebastian Kazazi. I've butchered your name. I'm sure you can help us with the correct pronunciation.
Can you hear me now?
Hi, Seb, how are you doing?
I'm good, thanks. Yeah, Sebastian Kazazi. Close enough, all right.
Do you want to try sharing your screen?
Yeah, let's see what happens.
So Seb will be talking about the confidence amongst surgical staff on sterile surgical PPE protocols for operating on COVID-19 patients. I can see your screen. Whenever you're happy, you just crack on.
Yeah, all right. So good afternoon now, I suppose, to everyone. Thanks for joining me on this presentation, which Tom has kindly introduced. And I think it actually also follows on nicely from Tom Riley's presentation just now. So as I've been introduced, I'm Sebastian Kazazi. I'm one of the core surgical trainees in London, and I did this project along with Sophie Harston under the supervision of Mr. Paolo Sorelli. So just to set a bit of background then, as I'm sure you will know, during this COVID pandemic, I think there have been ample opportunities for members of the general public to be very creative with their sort of PPE use. And while this has been endlessly amusing to myself, and I'm sure others, it's actually quite a serious topic, especially for us in the healthcare business. So around April 2020, which is the first peak of our COVID pandemic, there were lots of sort of whispers in the theatre coffee rooms that no one really knew how we were meant to be donning and doffing with regards to operating on patients. Because although similar, the actual process of doing this for operating is slightly different, given that you need to maintain sterility. So we felt that by improving knowledge and confidence among surgical staff, we could improve patient safety by maintaining the sterility and also improve staff safety by reducing COVID transmission. So our aims then clearly were to improve the level of confidence and preparedness in surgical staff while scrubbing for surgery using personal protective equipment. Generally, we thought the incentive here was to improve patient and staff safety, as previously mentioned. So how did we go about doing this? You can see on the screen there, we have our survey up, and we used SurveyMonkey to basically distribute a survey, which was very short, via email and WhatsApp groups to relevant staff. Now, this included majority doctors, both from a surgical point of view and a critical care point of view, from F1 through to consultancy, but it also included theatre support workers and scrub staff. The questions can be seen once again on the screen, but what I'd like to highlight is question D, which is particularly on how confident people are with donning and doffing respectively. After we did our primary survey, we then rolled out our intervention, which was this set of donning and doffing instructional posters with images courtesy of Pan Surge Collaborative, who gave a lovely talk earlier. And on this, we have basically instructions step by step on how to don and doff safely for theatre. And there's also a QR code sort of embedded, which could be, which pulls you through to a video on this. These were placed in the donning and doffing rooms for the COVID theatres specifically, but also in open areas of theatres so that people could peruse at their own leisure. After we put up these interventions, 2 weeks later, we did the same thing again, except we made a minor change of question A being changed to whether or not staff had seen the posters or video and whether or not they felt it was helpful. After we did this, average confidence levels were calculated and then plotted onto a bar chart to look at change in confidence levels. So on to the results then. There's quite a bit going on in this slide, but what I'd like to draw your attention to here is the chart, particularly this sort of large red wedge, suggesting that 42.8% of people had had no training on how to use sterile PPE. And this is prescient because 62.8% of staff who were surveyed had already been involved in a surgical case where the patient was either known to have COVID or suspected. Of these people as well, 72.8% of people were quite worried about exposure to COVID. On to the main point that we were talking about earlier, about confidence. Looking at confidence levels over here, we can see that just over a quarter of people were not confident or not confident at all for both donning and also doffing, and 88.6% of people wanted further resources. Then we had to look at our sort of slightly changed question on whether or not people interventions. We found that actually it was quite good coverage, with 80% of people having seen our posters and videos, and of those 80%, 94% found it useful. We have similar levels on the right-hand side, with people being involved in scrubbing for COVID cases, as well as sort of concerns about COVID exposure. Again, looking at our kind of key point here with confidence, again, looking at the not confidence levels, we can see that we've actually managed to reduce these both for donning to 10% and doffing also to 10%. We can also see that people would still appreciate further resources, although this has decreased from the previous levels. So look at it from a slightly different point of view, looking at an increase in confidence. In our second and third sets of data here in the middle and on the right, we can see that there is an increase in the confidence both for donning and doffing. To conclude then, this was a study with limitations, as they all have. Firstly, there was some responder bias and also differences between response rates in the first and second cycles. We also noticed that there were actually no OBS and gynae responders, which actually was probably a very large chunk of people who were operating during. What I think we can say, though, is that overall the improvement in the mean average confidence was there. It was 13.4% for donning and 10.8% for doffing. Using sort of cheap, quick, and easy interventions over a short time frame, we appear to have made some improvements. Looking forward from this then, to finish off, if and possibly when a second cycle occurs, we would like to run this cycle again for a third cycle at least, and we'd also like to formalise a protocol within the trust just to make sure that everything's rubber stamped. So that concludes the presentation. Thank you very much for listening, and does anyone have any questions?
Thanks, Seb. Okay, let's bring them back on. Luke, since you're here first, do you want to crack on and ask a question?
Yeah, so it's a really good audit, and I particularly liked how sort of clear, because a lot of the stuff that's in sort of clear flow, that's really good. And that's coming from somebody who's rubbish at donning and doffing. And I felt personally most of my knowledge of donning and doffing has been taught by the nurses who actually do it properly. And I'm just wondering, between your cycle A and cycle B, how much of that improvement can be down to the poster and the QR code you've done, and how much is down to just nurses and just the and people who've now done the procedure more, they obviously feel more confident?
Yeah, no, I think that's the point. Now, we sort of expected there would be some general increase in confidence, given there was a bit of a time lag between our first cycle and the second. But part of the reason we chose that very short 2-week sort of turnaround between the first and the second was that we were trying to reduce the amount of sort of just natural increase that there would have been anyway. Now, we did consider running a third cycle even after the first wave had started to decline, in order to see if there was any sort of natural progression anyway. But actually, after discussing with supervisors, we felt that it was probably more relevant to do it again in a third cycle if there was a second wave.
Okay, fine. So Darren, go for it.
Thanks, Sebastian, for your talk. I was just one question about the efficacy of actually donning and doffing. Did you have a look? I mean, just out of the blue, how many of those trainees that actually donned and doffed went on to get COVID? Or were actually?
So this is not. It's not something that we looked into, and actually that is, you know, an interesting thing that we could possibly take forwards from here, and not something that had occurred to me. I don't know what kind of reporting systems there are in place, because of the way that the survey was run. I don't know if the people who replied the second time were exactly the same people as the people who had replied the first time. Yeah, so given that it's an anonymous survey, it would be difficult to track down any statistics for whether or not these people had actually then caught COVID afterwards, without any sort of element of self-reporting. So I think while it's an incredibly good idea, and actually I would actually like to think about that as something to take forward, and thank you for the idea. I don't know how feasible it is, given the way that we've run it, to actually look into that.
Fine. Thanks very much.
Okay. Any other questions?
No, that's it. Thanks.
Fantastic. Okay, so any concluding remarks, Luke? Are you muted?
My closing comment is just the quality is really high. Some sort of big studies, some very good prospective audits. It's really good. Yeah, well done, everyone.
Yeah, same. I echo that. I think the broadness of all the presentations. Sorry. Yeah, I just wanted to thank everyone for their presentations. I, agree with Luke. It was quite a broad range of different types of presentations. It was very interesting. Thank you.
Awesome. Thank you so much to our judges. Great questions. Got everyone thinking. And if you want to head over to the expo booths for any of those various videos, the post presentations, and we'll see you back at 2 on the stage for